Good day, friends, and a warm welcome to Season 2, Episode 5 of 4D, that is Detailed Discussion and Dialogue in Indian Diabetes. We are together in this journey of learning, of gaining wisdom, gaining information, and we are working towards a healthier, a happier India. Today, let's invite one of the topmost experts of diabetes from across the country, Professor Swati Srivastav, Professor and Unit Head at the SMS Medical College, Jaipur, Chief Consultant of the Thyroid Clinic in the hospital, and also Chief Consultant at Dr. Swati's Diabetes, Thyroid and Metabolic Clinic, situated in Jaipur. Madam is a fellow of the prestigious RCP Edinburgh, the ICP, and Diabetes India. And she has won virtually all the gold medals that were available during her MBBS and MD time. Madam, I really wish you could have left a few medals for the poor little boys who were in your class. Madam seems to have won every gold medal that she encountered on her way during MBBS and MD. She now teaches MD students, and those students are very lucky who work under a Dronacharya like her. But let's learn today from Madam, from the Dronacharya of Indian diabetes, about cardiovascular disease and diabetes. Let's learn about the connection between CV disease and diabetes, and also let's learn how to break this unholy nexus, how we can fix up cardiovascular disease, prevent it, manage it in people living with diabetes. Once again, welcome everyone to the show, and Madam, the floor is yours.
Hello, all. I'm Professor Dr. Swati Srivastava. I'm a senior professor and unit head at the SMS Medical College, Jaipur. And I'm a practicing diabetologist and metabolic physician at Jaipur itself. So it's very nice to be here to be discussing diabetes and cardiovascular risk. Can I have my slides, please? So, diabetes and cardiovascular risk disease, are they partners in crime? Why do we say that? Is because we know that diabetes and cardiovascular disease are two chronic disorders which lead to a very significant increase in burden of an individual's life. So, if we go to the next slide, please. If you see that the burden of prevalence of diabetes, if we see in the society, is 9.6% amongst adults aged 20 and above. In India, we have around 1 in 11 individuals who live with diabetes. And what is more important is to note that 1 in 2 individuals do not know that they have diabetes. So, about for 53.1% of adults living with diabetes are undiagnosed. Now, the number of people living with diabetes in India, we see in the world, is the second highest, just after China. So, we have a huge burden of people living with diabetes. We have a huge burden of people who are undiagnosed and having diabetes. And this all becomes very important. Why this becomes important? Because disease is an important factor which is a usual cause of significant morbidity and premature mortality as well. If we just look into the data of cardiovascular disease, we find that according to the International Diabetes Federation, the prevalence of coronary artery disease among diabetic population is 2.5%. In general, we can say that a diabetic person would have a 2 times higher risk of developing coronary artery disease, cardiovascular risk, as compared to a non-diabetic person. So the risk of cardiovascular disease, which is so important for the morbidities, for the mortalities, is much higher in a diabetic individual. That is what is important, and we should always bear in mind. Studies have shown that more than 65% of patients with diabetes die of cardiovascular disease, out of which 80% are attributable to coronary artery disease. So, in a diabetic also, what is the cause of mortality? Usually, it is a cardiovascular disease. And cardiovascular disease, kidney disease, proteinuria, these are some important factors we know are very important as a negative risk factors and risk factors for premature morbidities and mortalities. Another point to note is that mortality after an acute coronary event is also 40% higher in Asian Indian patients. Now, this again has to be borne in mind that the Asian Indian patients have a different phenotype and genotype as compared to the Caucasians that we usually see in the population. So, what is seen in the Asian phenotypes, Asian Indian patients, is that the coronary event, if it occurs, the mortality is much higher. Now, going to the next point is the Framingham Heart Study we see. The diabetes and CVD. What we see is that in the Framingham study is that if there are a single risk factors, as we can see, what are the risk factors? If we look into the outcomes of any coronary artery disease, we see that the risk factors, strong risk factors, are if the BMI is more than 27, if there is smoking present, if the cholesterol is more than 220, if there is diabetes present, and if there is hypertension. So these are the individual risk factors, and if any of this risk factor is present, then the odds ratio goes high to as much as 1.7 to approximately 2 plus. Out of that, smoking is very important, and diabetes is the second most important. If you can see the odds ratio rising on this graph. But what happens if there are multiple risk factors? So, if there is a smoking which is present plus BMI of more than 27, the odds ratio doubles. Smoking plus BMI more than 27 plus a cholesterol getting elevated, BMI, the odds ratio triples, is more than 3. If there's smoking, high BMI, total cholesterol, and diabetes, the odds ratio goes to 4. And along with hypertension, if all these risk factors are present, it is very, very high, about 5. Again, if we look into the relative risk ratio in men and women, we find that total CVD and CHD is higher in women, cardiac failure is higher in women, intermittent claudication is higher in women, but stroke is higher in men. So, these are some important points that Framingham Heart Study has highlighted, that these risk factors are so important, and many of them, as we know, are modifiable. To some extent, the genetic aspect, yes, it is non modifiable, but the environmental factor and so many other factors like smoking, controlling your BMI, controlling your blood glucose, controlling your blood pressure, and controlling your blood lipids. These 4 5 things are very important, and which can reduce the occurrence of a coronary artery disease. And if it occurs, then the outcome can also be improved if these things are controlled. Next, please. Now, if we go into the pathogenesis of CVD in diabetes, now, why does diabetes directly lead to an increase in the cardiovascular risk in people, in individuals? Now, that's a question that comes in our mind so often. So, what is important to know is that hyperglycemia and intracellular metabolic changes which occur in diabetes are very important because they lead to a cascade of events which are deleterious and lead to occurrence of CVD. How does that occur? The metabolic changes which are occurring within these cells lead to an increase in the glycated proteins, the advanced glycation end products increase. And in a person who has a genetic predisposition, the presence of these advanced glycated end products, the AGEs, they lead to an increase in the oxidative stress. There are various other mechanisms as well in the form of the hyperinsulinemia, the insulin resistance, the increased free fatty acids, hyperglycemia. What do all these things do? They lead to again an increase in oxidative stress, number one. Number two, they also lead to a low grade inflammation. So, what is seen is that in the entire processes that go on, including the processes via the liver, where we have an increase in the C reactive proteins, increase in the fibrinogen, increase in the plasminogen activator inhibitor 1, all these lead to an increase in inflammation. They also lead to endothelial dysfunction and a thrombotic profile. So, what do we have? We have, if, as we see in the next second picture here, that we have an increased oxidative stress, we have endothelial dysfunction, we have low grade inflammation, and to top it all, we have the dyslipidemia and the blood pressure abnormalities, which further aggravated, ending and results into a thrombotic event either in the heart or in the brain or even elsewhere. Next slide, please. So, prevention of CVD in diabetes. Now, having seen what pathogenesis we are going to have in a diabetic individual, especially with regard to the cardiovascular disease, is there anything we can do about it? What can we do to prevent it? Because knowing is not important alone, we have to do something to correct it. So, what we realize is that the CVD can be prevented or delayed by controlling the blood glucose, number one, and the blood pressure and the serum cholesterol. So, it has been shown clearly that a blood pressure control and a cholesterol control is very important, and along with it, a blood glucose control also, along with stopping of smoking and a good lifestyle. A good lifestyle means eating healthy, nutritional, balanced diet, improving our physical activity. All these efforts will definitely lead to a prevention or delaying of the cardiovascular events. Now, when we see the cardiovascular events, we say we can have primary prevention also, meaning that we can prevent the initial occurrence itself. We do not let the CVD to occur in patients with type 2 diabetes, or we can delay the onset of CVD. This is what we mean by primary prevention. So, by taking care of all these measures like a control of blood glucose, blood pressure, lowering the cholesterol, having a good lifestyle, good nutritional diet, and improving physical activity, we can have a primary prevention of the CVD. At the same time, we can also have a secondary prevention, which involves treatment of risk factors in diabetes patients with established CVD. Next slide, please. So, the therapeutic strategies, if we see, in addition to the lifestyle and prevention of the risk factors we just mentioned, is there any treatment, any therapeutic strategy which can help us reduce the CVD occurrence and improve the outcomes and reduce the and have a secondary prevention as well? Yes, we have. How can we do it? An early initiation of combination therapy is usually an approach to achieve glycemic goals earlier and delay the deterioration of glycemic control with possible better preservation of beta cell function. Now, how do we achieve all this? We can see it more in a simplified manner is that the newer medication therapy which we have, if we use along with the diet and exercise to control high blood glucose in type 2 diabetes, some of them can help us in reduction of cardiovascular disorders as well. So, what are they? So, if we look into it, classically, literature has shown that two groups of agents, number one is the GLP-1 receptor agonists and the other are the SGLT2 inhibitors, which have a clear-cut impact on reducing the in having a better outcome and reducing the cardiovascular events in atherosclerotic cardiovascular disease patients with diabetes. SGLT2 inhibitors, if we see, the canagliflozin, dapagliflozin, and empagliflozin are the ones which are used. And in GLP-1 receptor agonists, we have glucagon-like receptor peptide receptor agonists regulate and restore the incretin functions. Now, these are not only the drugs, DPP-4 inhibitors are also useful. How? Because DPP-4 inhibitors, sitagliptin, sexagliptin, linagliptin, and alogliptin, they work on the incretin-based pathogenesis, and they also have some beneficial effects with regard to the CVD outcomes. Let's see how. If we see the SGLT2 inhibitors and DPP4 inhibitors, and if we combine these both, they form a smart combination. Now, why do I say that? For saying this, first let's look into the SGLT2 inhibitors, how they act. They act by reducing the tubular renal tubular reabsorption of glucose and promoting the glucosuria. So they have an impact on reducing the blood glucose. At the same time, they have an impact on reducing the systolic blood pressure by around 4 to 5 millimeters mercury, diastolic blood pressure by around 1 to 2 millimeters of mercury, and they have also they reduce they have a very low risk of hypoglycemia because they work depending on the level of the glucose. If the glucose levels are low, the tubular reabsorption is not going to occur so much and the person will not go into hypoglycemia. So it has a mechanism acting via the kidneys. The DPP4 inhibitors, if we see, they have an incretin based therapy. In this, what is done is that the incretins have a higher effect by inhibition of the DPP4 enzyme, which degrades the incretin. And that is how, again, they are weight neutral and they have a low risk of hypoglycemia. So, if we have these two drugs acting on two totally different mechanisms of actions, what we see is when we see look at the glycemic impact, we find that they have an additive reduction in the HbA1c. So, SGLT2 inhibitors plus TP4 inhibitors fixed dose formulation is a suitable option for Indian type 2 patients because they have a safer impact, rapid control, sustained glycemic control. They improve insulin resistance as well as beta cell function. They reduce body weight also, especially the SGLT2 inhibitor and the BP also, which is these are considered as a extra glycemic benefits. They reduce the pill burden also and resulting into a better compliance, better adherence to the therapy and are cost effective also. So, if we look into the final impact as to what the SGLT2 inhibitor does, it promotes glycosuria, promotes beta cell sensitivity, but has an increase in the glucagon. DPP4 inhibitor counter this effect on glucagon. They reduce the glucagon. So what we have end result is a reduction in hyperglycemia, reduction in weight because of SGLT2 inhibitors. DPP4 inhibitors are weight neutral, reduction in blood pressure because of SGLT2 inhibitors. Next, please. Now, if we look into the studies which have been done, there's a DAPSI study which has used the fixed dose combination of dapagliflozin and sitagliptin, and they looked into what is the effect in improving blood glucose control among patients in 3 months. And what they found was this combination was an effective alternative treatment option for diabetes patients with adequate glycemic control, leading into a good control. As we can see in the graph, the fasting plasma glucose reduction was very good, and so was the postprandial glucose control at the end of the 12 weeks of therapy. If we look into the change in HbA1c, a baseline HbA1c from 8.9 at the end of 12 weeks, it comes down to 7.2, very close to the target. Now, if we look into the SGLT2 inhibitors, what impact they have with regard to the cardiovascular benefits, because we are talking about the cardiovascular benefits in patients with type 2 diabetes, and it has been clearly shown that SGLT2 inhibitors have important risk reduction in CVD events as well as in kidney events. And these benefits, as we can see, the declared TIMI 58 trial showed that dapagliflozin, if we see the first graph, we see that the cardiovascular death or hospitalization for heart failure both were significantly lower in the dapagliflozin arm as compared to the placebo arm. So, this trial showed that there was a significant lower rate of cardiovascular death, hospitalization, and heart failure with dapagliflozin. The second graph shows the MACE, the major adverse cardiovascular events. And what was found was that dapagliflozin was non-inferior to placebo with regard to the primary safety outcome of MACE. Now, it should be remembered that these cardiovascular benefits of SGLT2 inhibitors seen here are largely independent of their glucose lowering effects. What I mean by that is that they do have an impact on the glucose lowering, and indirectly that also improves in reduction of atherosclerosis and improving the CVD outcomes. But independently also they have a good effect on the cardiovascular death, the cardiovascular disorders, the renal effects, and heart failure as well. What happens to the CVD risk in these diabetic patients if we give this combination of SGLT2 inhibitors and DPP4 inhibitors? As we just saw, that if we give SGLT2 inhibitors, then there is a proven CV benefit, like as we saw in dapagliflozin in the declared TIMID trial, and empiric outcome has also shown for empagliflozin. So it's a preferred drug in patients with CVD, including heart failure. So when we talk about SGLT2 inhibitors, guidelines clearly suggest the use of SGLT2 inhibitors for patients with diabetes who have established atherosclerotic cardiovascular disease or heart failure. These are two indications where we have clear-cut evidence that we should use SGLT2 inhibitors. When we combine with DPP4 inhibitors, they also have a proven CV safety. How do we say that? For example, sitagliptin. So here at the TECOS trial, which has been done, it's a trial evaluating cardiovascular outcome with sitagliptin. What they found was that adding sitagliptin to usual care in diabetes patients with established CVD offered CV outcomes. So, risk reduction of hospitalization due to heart failure, if we combine both these drugs, then probably it's a suitable combination therapy in patients with severe risk, including heart failure. So, if we look into this entire setting, we see that if a use of SGLT2 inhibitors along with the PPP4 inhibitors have a positive impact on the blood glucose level, along with a very positive impact on the cardiovascular risk reduction as well. So, they probably form a good combination in patients who are at a high risk of CVD risk, as well as in patients in whom we feel that they may develop cardiovascular risk. They may form a good combination to start with. And especially as cardiovascular disorders are one of the major complications of uh, diabetes mellitus, as we know, uncontrolled diabetes diabetes mellitus and hyperglycemia leads to microvascular and macrovascular complications. A control in the CVD risk or drugs reducing CVD risk are always preferred, and hence this combination would be a good combination. Thank you.
Thank you, madam, for that wonderful discussion. Not only have you discussed the pathophysiology and the clinical features of both syndromes, you've also talked about management, how we can manage these conditions together in a pragmatic manner. Ma'am, lots of questions coming up for you. And one question is, are there any glucose lowering drugs which can worsen heart health, which can worsen cardiovascular disease? Are there any cardiotropic molecules which might worsen glycemic control?
Right, that's a very important question. And when we talk about glucose lowering agents, which may have a negative impact on the heart health, yes, as we know, some time back, some of the thiazolidinediones had been implicated in increasing the heart failure, and some of them had been removed also from the market on account of their impact on water retention and aggravation of heart failure. I am talking about the rosiglitazone, which was very much there, and I think that was the first drug which then led to the entire cascade of using testing the drugs for the cardiovascular outcomes, and the CVOTs ensued later on. So definitely, these thiazolidinediones have been known to cause some amount of weight gain and sodium and water retention, fluid retention, and may sometimes aggravate heart failure. So in patients in whom we do have a increased propensity to develop heart failure, we should probably restrain from using or use with care. Other than this, some of the even the gliptins, some of the DPP4 inhibitors, especially one of them, sexagliptin, did show some increase in occurrence of heart failure, and that also should be used with caution in a scenario where we suspect a decreased ejection fraction or any heart failure for that matter. Even in preserved ejection fraction, I would not like to use it. And with regard to some drugs which have a negative impact on the glycemic levels, the second part of the question again is a very interesting question, because we know that when we want to have a good cardiovascular outcomes, we want to have a blood glucose control, but we want to have a still better blood pressure control, and we want to have a very good lipid control. And some of the lipid lowering drugs, like the statins, may cause an increase in the glycemic levels and increase in the blood glucose. So that has to be borne in mind when we use these things.
Ma'am, more questions. One comment comes from a physician in Rajasthan. He says that there is a KG A1C paradox. Many times, when we prescribe triple oral therapy, fixed dose combinations, we are able to bring down the HbA1c, but we end up increasing the kg or the weight of the patient because of pioglitazone. And on one hand, we are trying to reduce cardiovascular events. On the other hand, we end up worsening cardiovascular health because of the increased body weight. So that is the KG A1C paradox. His specific question is, the marketplace is crowded with so many dual and triple oral therapy FDCs. In such a situation, what is the role of FDC of dapagliflozin plus sitagliptin? Can we use this safely? Will it help us manage both KG and HbA1c?
True, sir. That is, I think, I'm sure you also would agree with me that this is one of a very important, valid points, that whenever we are focusing on the reduction in the HbA1c, a good glycemic control, many a times we end up with having a weight gain, which counters our benefits which have occurred due to the glycemic improvement. So on one side we have an glycemic improvement, on the others, if we see the scale on the other side, we are increasing the risk factors by having an increase in weight by some of the drugs. not all the drugs, some of the drugs. As very rightly pointed out, the thiazolidinediones again may lead to an increase in the body weight. Insulin also leads to increase in body weight. Sulfonylureas also may lead to increase in body weight. So though we have a good impact on the glycemic level, our body weight is increasing. So at and one side, though a better glucose control, on the other side, the CV risk we are probably enhancing. And that has to be kept in mind. And for that, I think the SGLT2 inhibitors are one of the very important drugs that we have, which have a good glycemic control along with a weight loss and a blood pressure reduction. So multiple risk factors reduction. And if we add them with DPP4 inhibitors, as very correctly suggested by the person who questioned, as well as by you, that if we add it to a DPP4 inhibitor, then we are having the two mechanisms of action, the incretin based therapy along with an SGLT2 inhibitors, a fixed dose combination, which is good in the scientific value in the form that it has a better CV outcome, weight loss also, risk reduction also. At the same time, it is in a fixed dose tablet. So that improves definitely the adherence, lesser chances of patient discontinuation, and a better outcome, and relatively cost effective also. So I think this fixed dose combination would definitely is beneficial in these circumstances and should be used to the most.
Ma'am, two more questions if you allow. The next question comes from Dr. Bharti in Karnal, and she says cardiovascular disease is so common now in the clinics, in the wards, not only in medicine clinics but also in obstetrics and gynae. Yet, cardiovascular disease, when we speak about it, when we think about it, there is a strong gender bias. Everyone seems to think and speak in terms of male disease. So, what is the role of cardiovascular health, cardiovascular disease in women? What are the windows of opportunity? How can we help improve CV health in women living with diabetes?
So I'm so happy that this question has come up, because this is something which is very important, that women, if we look into the cardiovascular results in women, if we know in general, if we look into the outcomes which occur to a cardiovascular disease in a male or a female, we see there are definitely worse outcomes in women. There was a slide which was also showing the outcomes of all coronary artery disease, heart failure, everything being more in women as compared to men. Only stroke was more in the Framingham study. Stroke was more in men as compared to women. In general, women tend to have a worse outcome. In general, women tend to have outcome to coronary artery disease. But usually, because many factors, some of them like smoking and stress being somewhat higher in males, usually it is definitely found to occur. The coronary artery disease is more or less considered to be a disease of the males. But yes, it does occur in women also. We should always remember that the outcomes also may not be that good. So we have to be careful. How do we have to be careful? I would suggest that a primary preventative strategy be adopted. All patients who come, whether into the gynae clinic or a physician's clinic, any clinic, check a blood pressure, look into the basic investigations, look into the lipids, look into the blood glucose, look into the weight, which is very important, as we see physical activity being very good usually in males as compared to females. What we find that the females are probably not so much motivated to have a good physical activity. That also has to be looked into. So a dietary prevention plan, a good plan of lifestyle behavioral changes along with a proper screening measures, if simple measures, checking the blood pressure, checking the lipids on a basis, not very frequently, but yes, they should be done, so that we have a primary prevention as well as in established diabetics. Of course, we have to follow the same rule, that an annual screening program has to be done, so that we look into all these parameters and control them.
Thank you, ma'am. So, your message is a comprehensive management plan for everyone, and it is everybody's responsibility. All healthcare professionals should take up the responsibility of preventing cardiovascular disease, or if not possible, at least minimizing it in women with or without diabetes. Ma'am, last question comes to you from one of your students in Rishikesh, and he says, "Respected ma'am, thank you for having led from the front all all the activities related to better health, not only cardiovascular but also glucose lowering. Now, ma'am, you will be taking charge of the Indian chapter of the ACP, the prestigious American College of Physicians. So, ma'am, how can we work together as physicians in our own clinics separately? How can we work with you to improve cardiovascular health in people with diabetes, to improve diabetic management in people with cardiovascular disease, and in each and every citizen of India?"
Thank you very much, and I would like to give my regards to all the members of ACP who have, helped me out throughout this journey. And what we would like to say is, Dr. Sanjay Kalra sir, you are one of the leading uh, endocrinologists of the country who does so much of education in the field of diabetes with so many webinars as well as so many lectures. So I think we can all work together in improving. Uh, Education is one important factor which is important not only for the patients, I think, but also for the physicians. What I feel is that the treating doctor, he has to overcome so many barriers that they have in mind, which are probably not very much of base, and they have to positively proactively look into the fact that we have to have a comprehensive care of our patients, where we look into all the parameters, not just the small parameter that the patient has come to us, but we should looking for the basic, like a blood glucose testing, a blood pressure testing, weight, look into the weight, and an education regarding behavioral lifestyle changes, changes in your diet, changes in physical activity. And when we are involved in the field of diabetes and cardiovascular health, I guess we have more opportunity to educate people more, so that more specifically, rather than generally, give specific instructions, so that we have a society which has better impacts, which has a better result. As we know, we are growing with regard to diabetes. We are going to become the diabetes capital. We have almost become. We should not become the capital of coronary vascular diseases as well. So let's have a better society which has a better outcome and lives better, more disciplined manner, with diabetes, without diabetes, with cardiovascular health, without cardiovascular health, either ways.
Thank you, Professor Swati Srivastav. To all of us who have joined in, this is 4D. Our second season is going on. And to 4D, let's add a fifth D today, thanks to Madam Srivastav. 4D is detailed discussion and dialogue in diabetes, in Indian diabetes. But the D that we have learned from you, Madam, today is dynamism. So thank you so much, Madam, for bringing dynamism to this aim of ours. And I'm sure that we'll work together to achieve the ambition that you've laid down. Uh, Healthier, a happier, a more harmonious society for each and everyone in our great country. Thank you, Madam, and Jai Hind.
Thank you so much, sir. It was really a very, very much privilege to be here with you. Thank you so much. Thank you, everyone.